automatically does it.
That's okay. Let's just keep it recording. Hey, everybody. Thanks for coming to Georgia MemoryNet Insights. We're going to get started in just a couple of minutes. Excited about today's speaker, Stephanie Vyverberg, and we're going to be talking about dementia with Lewy bodies. So hang on for just 1 minute, and then we'll get fully started. Thanks. Thanks for joining GM Insights. We'll start in about 30 seconds. Thanks for joining our webinar. We'll start in about 15 seconds. Hey, thanks so much for joining GM Insights today. You've got a treat today. So when we look at Georgia MemoryNet memory assessment clinics across the state, the most common diagnoses are Alzheimer's disease and vascular dementia. But we also see a fair amount of dementia with Lewy body. When we've been talking to our primary care provider colleagues, they've said, well, we don't really see that in our clinic. And so today's topic is, well, maybe you do see it, but you just don't recognize it. So we're very pleased to have Stephanie Vyverberg, nurse practitioner, who's from Emory's Cognitive Neurology Clinic, who works very closely with us in the Memory Assessment Clinic core and the Primary Care core to walk us through, maybe you do see this about dementia with Lewy bodies. Stephanie, over to you. Thanks so much for joining.
Thanks so much, Ted and Emma, and welcome to everybody who has joined us today. Excited to talk about this topic. And just 1 minute. All right, can everybody see my slides?
Perfect. That's your first slide and looks good.
All right, thanks so very much. So thrilled to have you all here. And as Ted mentioned, I think one of the motivations behind this topic is that Lewy body dementia is something that is way more common than we may think. And yet, without some base knowledge about the disease and how it might present and how it might even overlap with other syndromes that you're seeing in your clinic, either in the specialty care setting or the primary care setting or even the emergency room, we might miss it. And I would like to argue that if we miss it, it might have pretty significant implications for our patients, for their caregivers, and for us as clinicians as we try to treat these various types of neurodegenerative diseases. Just want to share our accreditation statement and CME information here. And also state that I have no disclosures. And as I've mentioned, we want to spend some time today really talking about those key clinical and neuropathological features of dementia with Lewy bodies and understand the clinical syndrome, both how it differs, but also how it might overlap and why that matters. And then understanding the impact on the quality of life of our patients and caregivers, and spend a couple of minutes at the end talking about some key management considerations. And so treating patients with Lewy body dementia comes with some very specific key points that if you know them, you might make a difference in the outcomes for your patients. And so I want to start with this slide. I know we can't really raise hands here, but hopefully some people on the call remember the rave back in the 90s of these magic eye posters. They might have been on your wall as a teenager, or you were like me and thought, I've never actually seen the 3D image that's supposed to be popping out at me right now when I look at one of these magic eye posters. And I think about that kind of like I think about Lewy body dementia. When I talk to my colleagues, even those in our movement disorders clinic, they say, I don't know how much I'm seeing this disease. And what I hope to be able to do is provide a little more clarity so that you're not squinting like I am at the magic eye poster trying to see that 3D image that's supposed to pop out at you, so that you might see some of the key features and say, hey, I need to pay attention to this so that I can do a better job of managing my patients. Many people don't know that it is the second most common degenerative dementia worldwide and affects greater than 1 million patients in the US. And by definition, it is defined by the accumulation of these diffuse alpha-synuclein inclusion bodies that we call Lewy bodies in the cerebral cortex. It tends to distribute in the cortex more so in Lewy body dementia than it does in Parkinson's disease. And it's distinguished from Parkinson's disease dementia, although similar, and some might argue actually that there's some overlap between the two syndromes and that they might actually be a very similar pathologic syndrome, but phenotypically expressed differently. But it's distinguished by timing. And so most patients with Lewy body dementia are presenting with their cognitive decline much earlier in their disease process as it relates to their motor symptoms. Whereas with Parkinson's disease dementia, and I'll show this on a slide later, that dementia comes on much later, way past when they've developed their primary motor symptoms. And so these are just some key things to be thinking about. Before we dive into the topic itself, I want to get a sense of who's in the room today. And so you'll see in your poll, I want to get a feel for whether or not you fit in the camp of, oh, I've seen this at least a dozen times in my clinical practice, and I feel quite comfortable diagnosing and treating this condition. Or do we have folks in the room that maybe have seen a few cases, but they're not super comfortable with the identification and diagnostic workup of these patients or treating it? Or do you fall in that camp that many fall in that say, I'm not sure I've ever even seen this disease? And so take a minute to take a look at your poll and fill that out for me if you can. I don't know if I have the ability to see those responses, Emma, on my screen.
So we have about 50% of participants have voted, and they're still voting.
Okay, great.
And just a little more.
Oh, here we go.
14 of
Perfect.
20.
So
Yeah.
about 50% of you feel quite comfortable and have seen several cases. About 36% have seen a few, and then about 14% are not quite sure if they've seen it before. So great, have a good mix of folks who are going to keep me accountable today. So I want to start by talking about the cost of Lewy body dementia. And while this slide is really getting at the healthcare financial burden of the disease, I don't want us to miss the actual cost of caregiver burden and impact on patients of this disease beyond just the financial burden. So what I want to point out here is that when we look at the cost and the duration of hospital visits for patients with Lewy body dementia versus Alzheimer's disease, we see almost double the cost. And what we find is that the complexity of this disease so greatly impacts the likelihood of a patient either being hospitalized or having complications while hospitalized, because of things like incontinence, because of dehydration and how it affects them, because of the autonomic dysfunction that might lead to a fall or that might lead to low blood pressure and unresponsiveness. Many of my patients' families call me saying, I'm pretty sure my husband's having a stroke right now. Come to find out, it's one of these classic either fluctuations or sensitivities to medication, or they're just dehydrated, but they present with much more severe symptoms. They also have a lot of depression and anxiety. And they have really high rates of delirium. And so recognizing these patients not only impacts us in terms of on a healthcare side, in terms of the burden and cost of care in our nation, but also, as you can imagine, everything I've just listed is a great burden to families and to patients. And then when they end up in the ER and they get put on an antipsychotic because they're confused and delusional, then they're there for an extra week because their body didn't tolerate that antipsychotic as well. So really important to understand the impact of this disease and the cost. And that's why we want you to be able to recognize it. However, most of you who've seen this disease recognize what I've come to recognize in my practice is that it's often not just one disease. And what we have learned over many years of studying is that Alzheimer's disease and related dementias is a term because we have several causes of dementia. And when you look at the umbrella of dementia, underneath that all causes and the ones that come, there's also a ton of overlap, which is what this visual is trying to show us. And so this tiny sliver here is pure Alzheimer's disease. Everything else is some form of a mixed pathology. And Lewy body is probably one of the most common overlapping syndromes that we see with Alzheimer's disease. And in Lewy body patients, we see a ton of Alzheimer's pathology. And I know this range is huge, between 28 and 89%. That varies depending on which article you look at, depending on the age of the population as well. Much older populations have more co-pathology. But that only I only point that out because when you're seeing patients with Alzheimer's disease, even if they have positive Alzheimer's biomarkers, many of these patients will also have Lewy body pathology. It may emerge later as you're following them over time, but when you start to see some of these classic Lewy body symptoms, I want you to think about the possibility of overlapping or mixed pathology because it matters to patients and families. Because when they start to freak out over a hallucination or this patient has developed some autonomic dysfunction or some Parkinsonism, you being able to recognize that and treat those symptoms and also avoid the heavy antipsychotics that might make their symptoms worse is going to be better outcomes for your patients. And then the other thing I want to point out is that as we think about new monoclonal antibody drugs for Alzheimer's disease, one of the exclusion criteria for putting a patient on a drug like lecanemab or donanemab is that they may, if they have a co-pathology, we need to be very cautious about that. And so if you have a strong suspicion for coexisting Lewy body disease in your patients who you're considering for monoclonal antibody, be mindful of that exclusionary criteria as well. And so we need to be aware, especially in this evolving age of treatment. Now, all that being said, there's a good bit of overlap even in the pathological, as we look at the neuropathological features of Lewy body and Alzheimer's disease. And there's some differences between Parkinson's disease dementia and Lewy body dementia. So the way I describe this to my patients is that in patients with Lewy body dementia, and this is not scientifically perfectly accurate, but in my patients who want to understand the disease, I tell them that it's kind of like a cousin of Alzheimer's and Parkinson's. And so you may have some features of Parkinson's disease, you may have some features of Alzheimer's disease, and then it also has some of its unique presentations that are separate from both. But what I want to point out here is that there's a ton of overlap in terms of the alpha-synuclein pathology in our Parkinson's disease dementia patients and Lewy body dementia. But in Lewy body, we also see a much greater load of A beta or amyloid and tau. And so tons of overlap with Alzheimer's disease, as we've already pointed out. And so another reason why we titled the session What We Did. If you think you're seeing it, you're probably seeing it. And it is often presenting in our Alzheimer's patients, and the pathology is often quite similar between the two. This is to point out what I said earlier, because I think there's also a lot of debate around what's Parkinson's disease dementia and what's Lewy body dementia. And I think the key take home of this slide is that those who develop MCI and then dementia many years into their motor symptoms are much more likely to have Parkinson's disease dementia, whereas those who very early in their disease with their motor symptoms develop dementia, or even the dementia before the motor symptoms within that first year or so, are more likely to have Lewy body pathology. And that matters because it does often present with much more severe, especially dementia-related symptoms and some of the other things that we're going to talk about with the core clinical features. That 1 year is highly debated. And so I don't want you to fixate too much on the exact timeline, but if you feel like early in the disease, there's also cognitive impairment, maybe more likely Lewy body disease. If the dementia comes on much later in their disease course, probably more Parkinson's disease dementia. So I want to transition to talking about the key features of this disease with a quick question. So true or false? All patients with Lewy body dementia experience visual hallucinations, which are usually well-formed and commonly animals and people. Is that true or is that false?
Okay, we have 11 of 23 respondents thus far.
All right, great. You guys caught on to the word all. So that is a segue. Hallucinations are something we should pay attention to in our patients, especially if we suspect Lewy body disease. But it is not a required feature of Lewy body dementia. Some patients do not have true, well-formed visual hallucinations, and they still have Lewy body pathology. Okay, Ted?
Stephanie, I wanted to go back just a second. We've got a question in the question and answer section, and feel free to put other questions there too. And that was from Ambar asking about anti-amyloid targeting therapies, and how do you know that someone doesn't have coexisting Lewy body before you put them on these amyloid targeting therapies?
It's a great question, and I think it's something that we are struggling with in specialty care. My rule of thumb has been if I have a strong suspicion for Lewy body disease, so if they present with Alzheimer's features. They have positive biomarker, either amyloid PET or CSF, but they've got fluid hallucinations and they are quite Parkinsonian. I am pretty convinced they likely have coexisting Lewy body pathology, and I'm much more hesitant to put them on their on disease-modifying therapy. If it's very mild, I may go back to the drawing board. I don't want to spend this whole talk talking about confirmatory biomarkers, but we may consider some of the newer investigational type biomarkers and skin biopsy or other things to maybe rule it out. But I think in a general sense, if you're strongly suspecting it, I would be cautious about treating that patient.
Thanks so much. Just one general announcement. If folks are having problems with seeing the slide configuration the way it is, just type in the question and answer so we can troubleshoot. Thanks so much.
Apologies. Is it showing up differently?
I want to find out. Maybe it's just the settings on the viewer side. I'm not sure it's any different in terms of the presenter view. Thanks.
Okay. Yeah. Apologies. Happy to troubleshoot if I need to. Okay. So let's transition to talking about clinical criteria.
Let's just take a moment and see if we can unshare and reshare the slides. There's a couple of folks who are having difficulty seeing the slides.
Okay, let's try again. About now.
Let's go with that. We've got several people who can't see the slides and several people who see the slides perfectly. And so if you're watching on an iPad, for example, they've changed some of the settings. And so you have to slide over to see the slide and the speaker. But otherwise, let's just keep going. Thanks.
Okay, thanks so very much, Ted. So again, as we consider what we've just learned, which is that there's quite a bit of overlap between Lewy body disease and other dementias like Alzheimer's disease, I hold these clinical criteria somewhat loosely, but also think they're important in terms of considering whether or not this patient has a diagnosis of Lewy body dementia. Essential for a diagnosis is that they have dementia. And so a progressive cognitive decline that's severe enough to interfere with normal functions, we all know is important. If you have a patient with dementia who is also having visual hallucinations, fluctuations, and fluctuations I have learned over many, many years look different in every patient. Some of it is wild fluctuations in their cognition or their level of confusion or alertness. Some of it is fluctuations in levels of arousal, and they will actually have periods of severe somnolence or kind of altered mental status, and some is fluctuations in attention. But these fluctuations, which are very variably defined, are an important core feature. REM behavior is a disorder, is another one that patients and families often don't tell you about unless you ask, and so that's why a good history is so important here. But patients who are acting out their dreams, if they are kicking or thrashing or yelling out in their sleep, or their bed partner has moved beds because they're so hard to sleep with because they're so actively acting out their dreams, that is highly suspicious for Lewy body dementia. It's actually a core feature that may present a decade or so before symptoms develop. And so when we've looked at articles and studies looking at kind of the prodromal presenting symptoms of very early Lewy body dementia, we often see REM sleep behavior disorder as an early revealing symptom that might make you worried about a patient with maybe mild cognitive impairment having Lewy body pathology. Okay, and then another core feature is going to be that they have features of Parkinsonism. I will say we often see a slightly different presentation of their Parkinsonism than we do in traditional Parkinson's disease. The most common is this kind of motor slowing or bradykinesia. So these folks present slower. And this is also a little harder to define or to tweak out because the families don't come in saying mom's hand is shaking and she can't stop it, or she's very, very rigid and stiff. They often just gradually over time become more bradykinetic, and the family may not notice that, especially if they're with them, but they will say things like, she's not walking as fast, she's a little more unsteady, she's slower to do things. And so things to keep in mind as far as those actual motor symptoms and how they present. We do want to see at least 2 of those features to make a true diagnosis of Lewy body dementia. But again, the overlap with Alzheimer's disease makes it difficult. Some supportive features that we also just want to be mindful of is that most of these folks are sensitive to antipsychotics. And so that's helpful in history taking if the patient's been put on an antipsychotic and did very poorly, either became wildly confused or over sedated, it had terrible Parkinsonism or extrapyramidal symptoms. That those are features that might give you a clue that this patient might have Lewy body dementia. Also important to think about in your patients who have this diagnosis so that you don't put them on drugs that they're going to be sensitive to. These are the folks that I often put on half of a 25 milligram tablet of quetiapine if they're having delusions and hallucinations that are bothersome versus even a starting dose of 25 milligrams because of how sensitive they are. So it's important to notice that. These folks also have a good deal of posture instability or repeated falls, some syncope. We've already kind of talked about some of these fluctuations, but they can have periods of transient loss of consciousness. I don't see that quite as much in my clinical practice, but I do see quite a bit of autonomic dysfunction. And so they have trouble with orthostasis, with some constipation, incontinence, and urinary retention, things to be mindful of that can be really problematic and functionally limiting for these folks as well. They have a lot of issues with sleep. Many of them sleep a lot. And then we've already talked about the REM behavior disorder and how that shows up. They will have a loss of sense of smell. Don't always test for that in clinic, but just something to know. And they're more likely to have that loss of sense of smell. And then the hallucinations are not, as we mentioned earlier, always well-formed visual hallucinations, and they can show up in other modalities or can be what we call systematized delusions. The one I see most commonly in clinical practice, and I'll tell you about a lady that I've seen in clinic who had positive Alzheimer's biomarkers, but she was a little slow and Parkinsonian, and then she suddenly developed this fixed delusion that there were multiple versions of her husband Joe in the house at all times taking care of her, and that one Joe might come in the room and then leave, and then another would come in and he was there to make her dinner that night, but the man that she would see, who was actually her husband, was an imposter or a different guy, and that wasn't the real one. And so it created this very tense situation in her home where she could not distinguish who her husband was, or didn't even always remember that she was married. And so multiple visits with me, with the geriatric psychiatrist, trying to get her into a peaceful place in her own home because she was seeing these copies of her husband at all times. And now to this day, she's much more content, but she refers to the guy that brings her into her visit, who's been her husband of 50 plus years, as this really nice man that's come to take care of me. And super tragic, hard thing, but coaching her family on how to deal with that has been so critical. So just keep that in mind. If you're seeing this Capgras or imposter syndrome in these patients, it may be a sign that they have some Lewy body dementia, and then trying to coach patients through how, and families through how to deal with that can be a little bit challenging. But rule number one with that is don't argue and kind of normalize what they're seeing and help get them on a path to understanding if you can. A lot of these folks also have coexisting psychiatric symptoms of depression, anxiety, and apathy. Some of my most depressed patients are my Lewy body patients, so really important to be mindful of that. There are some very typical cognitive features of Lewy body dementia, and so it does often distinguish itself from Alzheimer's disease in the sense that we see more prominent executive dysfunction, attention problems, and visuospatial impairments. One of my colleagues used to say, if I see their clock, I can tell you if they have Lewy body disease. And so that's why I put this picture on here. There's certainly some visuospatial impairment, especially and when we look at the distribution of the pathology and also of the shrinkage we see on MRI, a lot of times it matches kind of that more posterior pattern of disease that then causes more of a dysexecutive visuospatial impairment in our patients. Their amnestic problems, their memory problems tend to be more of poor retrieval of information and less about trouble with recognition and encoding. So these folks don't repeat themselves as much. They don't necessarily have rapid forgetting like some of our Alzheimer's patients, typically. They will tell you that they're having more trouble with multitasking, or we got Dad a new phone and he used to be our guru with the new electronics and he can't figure the thing out. And so a lot of trouble with organization, planning, navigation, or learning new tasks. I've already
Stephanie,
yes.
Stephanie, if you're okay to just grab a couple of quick questions that are really
Absolutely.
good ones in the chat. Here's the first one. It's from Monica Parker. What additional testing is used to differentiate that it's Lewy body dementia? Is it CSF? Is it just the history and presentation?
So historically, we have gone with history and presentation. And if I suspect Alzheimer's disease or coexisting Alzheimer's disease, I will get Alzheimer's biomarkers first. So I'll either get a CSF or an amyloid PET, or now the new p-tau 217 test to try to determine, is this Alzheimer's disease? I don't always find that it's needed to do further confirmatory testing, but the DAT scan is sometimes used by our colleagues in our movement disorders clinic. The problem with the DAT scan is it doesn't just distinguish very well between Parkinson's disease dementia and Lewy body dementia. So if you're trying to distinguish between the two, it's not super helpful. But if you want an answer, a DAT scan can be helpful. There's some others that are less used. Even a positive sleep study for REM behavior disorder is considered one of the confirmatory biomarkers, as well as a cardiac scan as well. That, again, I haven't seen used a lot in clinical practice. There are a few newer investigational skin biopsy and CSF markers that can be sent, and I've seen a few of my colleagues send those recently as well.
Super helpful. Here's your other question from Ashley Varner, and that is about the case presentation that you just presented. And are you more often seeing this clinical delusion or hallucination of infidelity in dementia with Lewy bodies, or is that something that you see broadly across other diagnoses?
I think if we kind of put infidelity in that category of that systematic delusion, then yes. I have not seen the infidelity one as much in my own personal clinical practice and found it to be as specific. But anytime I think people are having a fixed delusion that is it's either parallel to their reality but different. I had another gentleman that swore that down the street there was a copy of his house right next door that he would sometimes go in and out of. Really interesting to kind of see that. So not a direct response to your question, but I do see some infidelity accusations in both Alzheimer's and Lewy body. But definitely the systematic delusions we see a lot in this disease.
Great. Back to you in this slide. Thanks.
Okay, great. So we already talked a good bit about motor features, but I can't emphasize enough that we don't want to miss it, right? So pay attention to that person's blink frequency, how they're moving. Do they swing their arms when they walk? And then the rigidity is often subtle. I find also that they're not as responsive to dopamine therapy. And so if it's severe enough to really impact their safety or their daily functioning, we will try them on carbidopa-levodopa and crank up that dose slowly over time. But be mindful too that can increase their hallucinations. So just important to note, they do not have as much of a response to dopamine as a Parkinson's patient might. Which gets me into management. Key takeaway in terms of management is that these folks have a greater cholinergic deficit than your traditional Alzheimer's patients. And so that means they're more likely to benefit from drugs that boost acetylcholine. And so we will often put these folks on donepezil, galantamine, or rivastigmine, and we will these are the folks whose family come back and went, wow, he did great. Can we have some more of that? Whereas my Alzheimer's patients go, don't know if I wouldn't have known if you'd put him on it or not. And so we do see a more robust response to our cholinesterase inhibitors. I often will try this, especially as a first line treatment for neuropsychiatric symptoms like these delusions and hallucinations, because it can help with that and keep you from having to put them on something stronger like an antipsychotic. With the caveat that these delusions and hallucinations are sometimes not problematic to the patient. And so if they are seeing a pleasant chamber orchestra in their room every night and they're happy about it, we don't need to treat their hallucination. And so I always tell people, coaching the family on how to reassure the patient when they're having these hallucinations is really the first line of treatment before you put them on therapy. There's mixed reviews on how helpful memantine is, but it might be helpful in moderate to late stage, especially if you suspect coexisting Alzheimer's pathology. And then the atypical antipsychotics, the one we use the most is quetiapine because it doesn't have as many of the side effects as others. But because patients in this with this disease tend to tolerate it better, but just be cautious, as we've already mentioned. And there's newer drugs out like pimavanserin as well. Not a whole lot of experience with that drug yet, and the cost may be limiting as well. We do want to treat their mood disorder and be careful with paroxetine because of its anticholinergic properties. And I've already kind of given a nod to what to do about Parkinsonian symptoms that are functionally limiting and problematic. But physical therapy and movement and walking can be really helpful for these folks. And then for those who do have REM behavior disorder, it's important to ensure they have a safe sleeping environment, get rid of drugs that might aggravate those symptoms, but then also if we need to treat, higher dose melatonin. If not melatonin, clonazepam, and then sometimes rivastigmine can be helpful. So I know I'm at time. If I have just 1 second, I'll throw you guys one more question, which is, your patient's wife reports that he sees children playing in the yard every evening. When she tries to explain to him that they don't have any children, he becomes very upset and agitated. What should be your first line of treatment? Should she start him on donepezil, because we know that he might have a more robust response to this drug, and might have a reduction in neuropsychiatric symptoms? Should you provide coaching to the caregiver, or should you treat his hallucinations with a low-dose antipsychotic like quetiapine?
Okay.
All right, awesome. Y'all were listening. So always coach first and try to help family not correct, and go, play along as best they can, especially if not distressing to the patient. And then we would consider some of these other treatments if needed, if they became really problematic, impacting quality of life or safety for the patient. So I will close with that and hand it back to Ted for a couple of these slides on what's coming up next.
And you have one question from Anna Merck, and that's, is there a role for skin biopsy in Lewy body dementia diagnosis or for synucleinopathy?
Yes, and so as I mentioned earlier, skin biopsy is one of the newer modalities for testing for Lewy body dementia. We are very recently beginning to order that in some of our patients. Here in the cognitive neurology clinic, I wouldn't necessarily say that it needs to be used out in primary care, but in specialty care it can certainly play a role, especially if you want to distinguish between diseases.
Definitely super helpful, a really engaging and informative lecture, and maybe people will see something that they're seeing, and so that's really helpful. I think we've got one more poll just to give us some information about you, and thanks for giving a quick answer to that poll. And looking forward to next month. We're going to have Dr. Law come on December 10th. And that's who's in the group. Thanks so much for coming. And just one note, we're about to move from Emory Continuing Medical Education to the Georgia Area Health Education Center's CME from Morehouse. So here's the good news. The good news is that Emory CME was very concerned about having this be an Emory only offering. And for us, we need this to be a statewide offering. So we need to have everybody on board. The other good news is that Morehouse has allowed us to get quicker approval of CME offerings. And so that's really good. The only negative is that you'll have to, starting in January, re-register with Morehouse in order to get your CMEs, but really excited about that. If you want to take a screenshot, these are the upcoming dates for next year's Georgia MemoryNet Insights. And thanks so much for joining us. Really appreciate you. And thanks, Stephanie. That was super awesome. Here's how to get your CME credit for Emory for both this month and next month. This month's webinar ID number is 21647. And so go ahead and write that down so you can get credit for that. Thanks so much, and really appreciate everybody joining us. Thanks again, Stephanie.
Thanks so much, everybody.